So the goals, I keep on coming back, of treating pain, especially chronic pain, is decrease pain, increase function, and use medicines that do not have unacceptable side effects. And certainly patient evaluation is extremely important, both initial and each evaluation. I'd like to introduce a term to you called universal precautions in pain medicine. My associate and my writing partner, Dr. Gorley in Toronto, Canada, we have published this in 2005, and the term universal precautions originated from the infectious disease model. Back in the late 80s, late 70s, early 80s, our colleagues, our professional colleagues, were faced with a dilemma. It was the start, really, of the epidemic of AIDS, HIV, hepatitis B, hepatitis C. And how did the infectious disease doctor protect his or her practice and protect his staff from the spread of this infection? They thought about it, and out of this came the OSHA laws, in which every physician has a red bag in their office in order to dispose on hazardous material. It's mandatory to glove and gown or use appropriate techniques if you're drawing blood or handling somebody else's body fluid. And through this, they were able to contain the spread of infection, at least through the medical community and also their community themselves. And so Dr. Gorley and I took this universal precautions and applied it to the treatment of chronic pain. And majority, or a lot of pharmaceutical companies, are now using the universal precautions as part of the risk management program. It's a careful 10-point assessment of all persistent pain patients within a biopsychosocial model. And notice I said a biopsychosocial model. In other words, writing a prescription for a patient for opioids is just one piece of the pizza pie. If I don't take care and make sure that their treatment for anxiety, depression, bipolar is taken care of, I will surely fall in having that patient reach his or her goals. So I want to do also appropriate boundary settings before writing the first prescription. And by using this approach to the pain patient, stigma could be reduced, patient care improved, overall risk of pain management can be reduced. What are these principles? Now, Dr. Gorley calls them the 10 principles. I'm Jewish with a beard, and I call them the 10 commandments. But as I go through these 10 principles, these what you want to apply to anybody who has a chronic medical problem. Forget about opioids, forget about pain. Don't you want, number one, a diagnosis with appropriate differential? Number two, a psychological assessment including the risk of addictive disorders. You have to treat depression when present, non-restorative sleep when present, bipolar disease when present. You have to ask about sexual abuse, physical abuse. That's all your part. You have to put all the pieces of the pie together. You want informed consent. You want a treatment agreement, and you really want it written. And what does a treatment agreement say? It says, what I will do for you and what you will do for me, what are mutual responsibilities of getting the privilege, I say the privilege, not the right, of me prescribing you a controlled substance and having the pharmacy dispense that medication. What is the responsibility on both sides? And you have to establish that responsibility before you write the first prescription. You want number 5, you want a pre and post interventional assessment of the pain level and function. How do you know where you want to go unless you document where you are? So you want to ask about their functional activity. You want to ask what their goals are with rational pharmacotherapy for the pain. And since we just finished the Olympics, one of the ways that I like to do it, I say, pretend we're in the Olympics. Give me the gold, silver, bronze, what you want to get out of rational pain medicine. I'm not interested in prescribing opioid medication for somebody to lie on the couch, eat bonbons, and watch Oprah Winfrey. They could probably do that without opioid medications. Because I ask, does any of your physicians, will they start insulin without doing a fasting blood sugar and hemoglobin A1C? Will any physician start a hypertensive medicine without measuring a blood pressure? Why would I start opioids without establishing a baseline? In other words, pain levels, 0 to 10, et cetera. Or what are you doing functionally and how we're going to work to improve it? And then once the patient gives me their goals, then we do appropriate trial of opioid therapy and adjunctive medication. Notice I said appropriate trial. An appropriate trial meaning a God-given right that it's not continued if we're not reaching our goals, or if we don't see that the patient is improving. So anytime that you prescribe a medicine, you have to have an entrance strategy, which I'm talking about, but you also have an exit strategy in case it's not working out or it's not effective. You want to, number 7, reassess pain scores and level of function at each visit. Regularly assess the 4 A's of pain medicine from Steve Pasick. In other words, every time the patient comes back to my office, how's your pain control from 0 to 10? What is your activity? Are you having any adverse effect? And is there any signs of aberrant behavior? And I have to document in that chart. And I have to periodically review the pain diagnosis and comorbid condition, including addictive diseases. And most importantly, I want to document everything in my chart. Document, document, document. Because if it isn't written in my chart, it's a figment of my imagination. I have to document this. And people have come to me when I speak across the country and say, Doc, I really can't document that my patient was chewing a control-release oxycodone. I say, definitely you document that in your chart. What is key is what you do with that information. What do you do to change the treatment plan based on that information? Remember, in my second life, I was a gastroenterologist. I've done thousands of colonoscopies. Having a colonic perforation is not malpractice. It can happen. It doesn't happen often, probably less than 1%, but it can happen. What's malpractice is me not recognizing the perforation and doing my due diligence in treating the patient after the perforation. So things happen, and they're not always good with our head patients, but we have to document it clearly in our chart. Universal Precautions also has a triage system, and we have to understand, based on our education, our comfort level, of who we should treat, who should be co-managed, or who we should refer out. And we think that Group 1 by Universal Precautions is the patient who should be taken care of by the primary care doctor. And that's the patient who has no history of addiction or psychiatric comorbidity. Group 2 may have a past history of addiction that's very well in control, very long in recovery, or very well-controlled psychiatric disorder, but that patient may then come to me for a consult and will co-manage the patient, or the patient will be referred back to me maybe twice a year for me to review the treatment plan and make recommendations. And Group 3 is a patient that the primary care doctor should not touch with a 10-foot pole, and that's a person with an active addictive disorder or an active untreated psychiatric comorbidity. That's the patient that I take care of. That's the patient that I'm comfortable with if they're willing to work a program for both. So whenever you see a patient, you have to know who is your patient, who is our patient, and who is my patient in regards to the triage scheme. And then never, never fail to get a consult whenever you need it. I mean, we get consults for cardiology, endocrinology, pulmonary all the time. Always consider getting a consult from one of our esteemed colleagues. But the key when you do get a consult, make sure there's good communication between you, the consultant, and the patient. Because if there's poor communication, who suffers? The patient suffers.